Laurie White to the stage, and Laurie will address coping with behavior changes in dementia.
Thank you, Linda, and good morning. It still is good morning to all of you. Linda gave me the large task of talking about behaviors today, and although I can't go into detail on the many behaviors that we associate with various types of dementia, I thought that I would give you just an overview of why they may be occurring and some things that you can take away and think about as it might apply to your situation. I'm happy to take more specific questions about behaviors in the Q&A, and also we have some postcards out there about the new book we wrote, and we'll have some books available later as well. So let me start with sort of the ABCs of behavior, and that really boils down in my book of attitude, behavior, and communication. So let's start with attitude. What is attitude? Attitude really is a view of something or someone. How do we think about it? What do we think about it? Do we accept it? Our attitude can change over time, and clearly our attitude towards a diagnosis, a disease, and behavior change indeed can change over the course of the years that a person has it. But let me just share a couple things with you. There are a lot of myths out there about Alzheimer's disease, Lewy body disease, and other types of dementia. For example, I'm often confronted into airports or when I do presentations that someone will say, well, all people with Alzheimer's are aggressive, right? Is that a fact or fiction? Thank you. Very educated group here. It is not. Each person will have some behavior changes. What we don't know is when those behavior changes may occur, if the person will have behavior changes at all, and how severe, moderate, or mild they may be. So we can't say that the disease, at least Alzheimer's disease, has a route that it goes, but it varies from person to person. So some people in the early stages of Alzheimer's will have very good communication skills. Some people may not. Some people in the later stages maybe have other challenges of their own, but have the verbal skills that we don't associate with the later stages. All those who wander are not lost. So oftentimes we do have a level of agitation and a person will wander. But the question really is, why is that person pacing, walking, or wandering? Could that person be looking for someone? Could that person be looking for something to do? Does that person feel vulnerable, frightened, unsure of where he or she may be, in fact, disoriented? As Robert Davis said in one of the first memoirs about Alzheimer's disease, written by someone with Alzheimer's disease, sometimes I have an uncontrollable urge to move. So that's another way to look at wandering. Again, about attitude. Our attitude changes over the course of time, and oftentimes is associated with the volatility or the changes in behavior that the person with the disease is experiencing. So we know, especially with Lewy body disease, that the behaviors in a person's abilities and needs can vary tremendously. But that can also occur with Alzheimer's disease and other types of dementia. So our attitude can be affected by that as well. One client recently told me that he said, quote, "I'm trying to change my attitude about my wife's disease from being a burden to being an opportunity." What was the opportunity for him, I asked. He said, well, it's an opportunity to learn, to try to understand why she does certain things, and if there are things that I can do to prevent the behaviors from escalating. When I understand things, I can cope better. And through the course of Alzheimer's disease, Lewy body disease, Parkinson's disease, there is a grief that occurs, I think, for the person with dementia, but also for family members and even professionals in the field. And grief sometimes prevents us from seeing things as they accurately are. And that's when it's really important, as Helen said, to maybe have a confidant that can help us through this journey and offer another perspective of what is going on, what we may be doing or could be doing. The B in the ABCs is behavior. So what are some of the behaviors that we associate with Alzheimer's disease, for example? Wandering, forgetfulness, confusion, agitation, and anger. So if we look at those symptoms of a disease, is it not a better way to look at them as a way of communication rather than a form of misbehavior? So I have a talk I often give that says, she ain't misbehaving, she's communicating. And so if we look at those behaviors as a way the person is expressing a need, a desire, a want, does it change our attitude about that behavior? I think it might in some cases. So when a person can no longer express what she wants or needs, she may be telling us these things through the behavior. Our job is to learn how to interpret these behaviors and what we might do to offer the person more comfort, more security, and more safety. The C is for communication. What we know happens through the course of the disease is that the person person's communication will change over time. What does that mean for us? That means our communication has to change over time. So there's a slowdown in processing and maybe a slowdown in expressing oneself. So if there's one thing that you take away today, and it not only applies to communication, but to other aspects of this disease, is to simplify. Simplify things. Simplify your communication to match the person's ability without sounding condescending or without treating the person as a child. So why do these behaviors occur? Well, we talked this morning, there's changes going on in the brain that account for some of the behavior changes. So memory loss, disorientation, attention span, other challenges in communication. We can't see the brain, so we can't fully understand why some of these changes are happening. It's not like you can see a swollen joint on someone who has arthritis. You wouldn't have the same expectations for that person in terms of perhaps exercising or walking, whatever it may be. We can't see in the person's brain, so we have to alter our expectations as well. The person may be in physical or emotional discomfort or distress. So rather than assuming that the change that we are seeing, whether it be agitation, aggression, wandering, rather than assuming that it's related to the disease, I think the first place to start is asking ourselves, is there something else physically that may be going on? So could the person have an infection? Could the person be in pain from an old injury? These are things to discuss with the doctor. Another reason for behavior change is, are we asking the person to do a task that she or he is no longer able to do because she can't remember how to do it. She doesn't remember the sequence of steps in the task. So sometimes people can get agitated or get verbally aggressive because they don't understand. Or the person can withdraw from some activities because maybe on some level, with some sporadic insight, the person recognizes that they can't do things. So why try to do them when you think you're going to fail? And the environment. So what is going on in the environment? Not just the physical environment, but the emotional environment. I know from being in the field for 30 years that people, even though they may not understand what I'm saying or what is going on around them, they have antenna and they can pick up on the emotional environment pretty darn easily. So what is our tone of voice? What are our facial expressions? How are we acting? But in addition to that, people with dementia can be overstimulated by noise, activities, sounds, and they can be understimulated, and they are bored. And when they're bored, can they initiate trying to find something? And if they are initiating and trying to find something to do or to be with someone, do we label that wandering? So we know that there's several different emotional responses to this, to Alzheimer's disease and Lewy body disease. We know that about 50% of the people suffer from depression. We know that about the same amount suffer from anxiety and depression. We know that wandering, 60%. And we know that agitation, which is a more physical anxiety, if you will, the projected is between 50 and 90%. So there are some emotional responses to this disease, and I think it behooves us to think about what we need to do for the person. So for an example, some of you may have had the experience of personal care, the person not wanting to take a bath, or the person not wanting to shave, to change the clothes, to go to the bathroom, to brush your teeth. So we know that assistance with personal care is a large issue in caring for someone with dementia. Why might that be? And just a few suggestions I may offer are assistance with personal care. Why do I need it? I just took a bath. So there's the memory loss that just occurred. Receiving assistance for personal care may elicit agitated or aggressive behaviors because they don't think they need it. There is a pride and an independence of a personal task that we've been able to do for ourselves all our life. And all of a sudden someone's saying, no, I will help you, or you need to do this. As we said, the person may not recognize the need for help. And if you're a care partner and you've been trying to get your mother, your spouse, your husband in to take a shower for a long time, how are you sounding? Are you sounding impatient? Are you frustrated? Of course you are. But again, picking up on that tone of voice may affect your ability to be successful in getting someone to do the personal care that he or she may need. So in summary, what can we do? Learn all you can about dementia that your relative has or that you suspect he has or she has. Learn all about the different types of behavior changes that can occur, but do not assume, again, that these behaviors will occur with your relative. But I think just knowing that they can occur and what they are can help us plan, especially in a safety perspective. Identify triggers. What might be causing the behaviors? In our book, we have a section called problem solving, and that is to look at some of the triggers and that might be causing agitation, maybe causing incontinence, etc. But also to have a problem solving log and keep track of what you've tried, what the behavior is, were you successful? If you weren't, what else could you do? And that can be very helpful. And be honest with yourself and be patient with yourself. This is a big job to care for someone with a dementia. And do you need a break? Do you need a confidant? Helen referred to some of the resources that are out there, and I would strongly encourage you to take advantage of those. What have people with Alzheimer's disease shared with me? These are quotes. I am doing the best I can, but don't expect that I will always do it right. The familiar always doesn't come back, and it takes a lot of energy to deal with other people's energy. Thank you.